Evening. This is Dr. John. Good evening. This is Dr. John Bennett from Miami, Florida. We're broadcasting live Google Hangout with Dr. Abdul Rana, a neurologist and noted Parkinsonism educator from Toronto, Canada. And tonight, Dr. Rana is going to be talking about Lewy body dementia and Parkinson's. Good evening, Dr. Rana.
Good evening, Dr. Bennett.
Okay, the first question is obvious. What the heck is a Lewy body?
Lewy bodies were described initially by a German pathologist, Friedrich Lewy, in 1914. And these are cytoplasmic inclusions in the cells of substantia nigra, which he described initially. And by 1970, Lewy body inclusions were identified in the neocortex of the brains of dementia patients. So Lewy bodies are named on Friedrich Lewy's name, who discovered them in 1914. And these are cytoplasmic inclusions. They have a dense core surrounded by a halo, and they are characteristic of Parkinson's disease as well as dementia of Lewy body disease. So there are certain differences which we will discuss in this hangout as well as in the next one. So the dementia of Lewy bodies was considered a rather uncommon disorder by mid-1980s when the immunostaining became more widely used. At that time, it was noted that it is a quite common neurodegenerative condition as compared to it was considered before.
Okay, it's not particular to Parkinson's. It's any dementia.
It is sensitive for Parkinson's disease, but not specific.
Okay.
It is also found in the dementia of Lewy body disease.
Okay, very good. Okay, can you give some, I guess you gave a little historical background right there. Do you want to say any more? You want to go on to the next question?
Lewy body dementia is believed to be the second most common cause of degenerative dementias in the elderly population, in the seniors especially. And about 15 to 30% of all dementia patients may turn out to be diffuse Lewy body disease. It may not be recognized early on. And upon the postmortem examination, the Lewy body aggregates may be found in about 1/3 of patients with Alzheimer's disease. And those patients could be referred to as a Lewy body variant of Alzheimer's disease. These cases present an overlap syndrome of the Lewy body disease and the Alzheimer's disease.
How common is Lewy body dementia?
The Lewy body dementia is seen in about 15 to 30% of patients with dementia overall. And it is the second most common cause of degenerative dementia in seniors, according to most of the reports. The mean age of onset is 75 years, and there's a slight male predominance. The diffuse Lewy body disease or dementia with Lewy body disease, it progresses relatively rapidly, and the mean survival of these patients is about 10 years, 8 to 10 years. However, some patients could die within a couple of years. There are certain factors, there are certain risk factors for increasing mortality in these patients, including dementia, fluctuation in cognitions, older age, and hallucinations at the onset of the disease. So if these factors are present, these patients would be considered at a higher risk of mortality. These patients have a neuroleptic sensitivity. About those patients who have high neuroleptic sensitivity, they also have higher risk of mortality. And some reports have suggested some familial cases of dementia with Lewy bodies, but usually it's considered a sporadic condition.
Okay, what are the common presenting features?
In the early on in these patients, it could be quite difficult to differentiate from other conditions such as Alzheimer's disease or sometimes idiopathic Parkinson's disease. These patients usually have a rapid cognitive decline. They have deficits of attention early on in the course of disease. The dementia or the cognition is the main presenting feature, the trouble with cognition. The cognitive fluctuations happen in these patients with much higher frequency. Sometimes they could be coherent and alert. At other time, they could have episodes of confusion and disorientation and change in level of consciousness, as well as psychosis. The fluctuating cognition could cause problems with the assessment because depending upon the condition of the patient when they are being assessed. So the assessment may give different results. If they are coherent and stable during that time, so assessment could be different as compared to if they are going through a fluctuation in level of in their level of alertness. So the result of the assessment could be different. These patients could have excessive daytime drowsiness, excessive daytime sleepiness, which is usually longer than an hour and a half. And they also could have slurred speech, and they could be sometimes staring, just staring absently without any cause. These patients, because they do develop features of Parkinsonism, so it becomes difficult to differentiate them from idiopathic Parkinson's disease. So most experts follow a rule of 1 year occurrence. So if the cognitive difficulties and hallucinations and fluctuation level of consciousness, so these difficulties start in either before the onset of Parkinsonism or within 1 year of the onset of Parkinsonism, then they consider the diagnosis of dementia with Lewy body disease. But if these symptoms occur more than a year or after a few years of the onset of features of Parkinsonism, then most experts would say that it is a case of dementia with the Parkinson's disease. The 80%, most of the patient, or about 80% of the patient, would experience the fluctuations and the hallucinations. The hallucinations are quite psychotic, and these patients have quite complex hallucinations. They're rich in content and color and detail. They involve humans or animals. We have seen patients who had very detailed hallucinations. They would describe the stories of talking to people they saw during these episodes, although these people had deceased some time ago. Sometime they would describe the kids in their front lawn or people in their house, and they give quite detail. Most of the time, these hallucinations are not frightening. In certain cases, they could be upsetting or they could be frightening to the patients, although it happens much less often. These patients sometimes may be amused by these hallucinations, or they might have a bit of apathy or inattention. The hallucinations may be accompanied by confusion or agitation, and REM behavioral disorders are also common in these patients. The hallucinations could occur more commonly than the psychotic episodes in these patients. Most of these patients would develop akinetic rigid type of syndrome without any tremor. So their symptoms of rigidity in bradykinesia or akinesia are usually symmetrical. They are usually on both sides, although they could be asymmetrical in certain cases. Some patients could have an action tremor and a myoclonus as well. And sometimes the myoclonus may start before the onset of dementia in these patients. Few patients, very few patients may have a subtle one-sided resting tremor, which may affect only thumb or their index finger or just the hand, although it's quite mild and is seen in a small number of patients. These patients could have trouble with their balance. They could fall frequently. They have difficulty with their gait as well. The gait and postural instability could become prominent as the disease progresses. In addition, these patients could be slow in performing their repetitive movements. Their gait could be shuffling as well. And that shuffling pattern of gait may make it difficult to differentiate them from idiopathic Parkinson's disease in some cases. These patients,
I'm sorry, go ahead. I'm sorry.
Yeah. As I said, these patients may fall frequently, and they do have depression in a significant number of patients. Transient loss of consciousness could happen in these patients, and they are quite sensitive to neuroleptics. The neuroleptic sensitivity could happen at much lower dose of neuroleptics, and even with the atypical neuroleptics, which are quite safe. These patients also get worse with the dopaminergic medications. Their hallucinations may become worse sometimes. They could respond well, or better at least, to the cholinesterase inhibitors. So therefore, rivastigmine may be helpful in these patients. It could not only help in cognitive dysfunction, but it could also help to decrease the hallucinations. Patients also have a combination of cortical and subcortical neuropsychological impairment, such as deficits of attention and visuospatial dysfunction. And these patients have particular difficulties in copying figures, and their memory storage may exceed the memory retrieval. About 30 to 40% of patients would develop depression sometime in the course of the disease. The rate of depression is almost as close as in idiopathic Parkinson's disease. Orthostasis, or lightheadedness upon assuming upright position, is also common in these patients, although it could be asymptomatic in some cases. And in other cases, patients may have episodes of syncope. The symptomatic orthostasis is less common in these patients than the other types of atypical Parkinsonism, such as multiple system atrophy. However, when autonomic dysfunction appears early on in these patients, so some patients may be misdiagnosed as multiple system atrophy. Usually, autonomic dysfunction appears later in the course of the Lewy body disease in most patients. The rate of progression of the dementia with Lewy bodies is faster than Alzheimer's disease. And if you do MMSE on every visit and then compare their MMSE scores annually, they usually would show at least 4 to 5 points of drop of MMSE score every year. And the disability in dementia with Lewy bodies progresses a bit faster than idiopathic Parkinson's disease, or at least equivalent to idiopathic Parkinson's disease. Lack of mobility due to slowness of movements, swallowing problems, and pneumonia are common in these patients. Because of lack of mobility, these patients may be bedbound for longer period, which could lead to skin ulcers. And aspiration, pneumonia, could be a cause of hospitalization and death in many patients.
Well, you kind of addressed this partially before about the pathological changes in the first question. Is there any other remarks you want to say about the pathological changes in the brains of these patients in Parkinson's?
In case of dementia with Lewy body disease, the cortical Lewy bodies are considered the pathological hallmark of dementia with Lewy body disease. They do have Lewy neurites and cortical senile plaques and spongiform changes. These Lewy bodies, they are concentric cytoplasmic inclusions, and they do have a non-membrane bound granulofilamentous structure. Most Lewy bodies are single and spherical, but sometimes they could be multiple and they could be pleomorphic as well. The Lewy bodies usually, they have a dense amorphous central core with a periphery which is composed of the radially arranged filaments. If you use an electron microscope to examine these brains, so you can see the Lewy neurites. They have haphazardly organized filaments, and they do lack a dense core. The main component of these Lewy bodies is alpha-synuclein, and the cholinergic neurons of the basal forebrain, as well as the monoaminergic neurons of the locus coeruleus, dorsal nucleus of vagus, and substantia nigra are the common sites where these Lewy bodies are seen in patients with dementia Lewy body disease. The Lewy bodies do occur in the posterior and lateral hypothalamus, but they are sparse or much infrequent in the basal ganglia or in thalamus. The postmodern studies of these brains would occasionally show Lewy bodies in the substantia innominata as well as dorsal raphe nuclei. The Lewy bodies are the dementia of Lewy bodies. Its course is usually correlated with the cortical denervation of the cholinergic neurons and the reduction in the choline acetyltransferase activity.
Very good. Let's see, what are the key diagnostic features of Lewy body disease?
The patients, when they are presenting initially, they would be presenting with any other neurodegenerative dementia. So the physicians in the early cases have to be very keen and vigilant and have to take a very detailed and in-depth history and do a physical examination with a very detailed cognitive assessment to conclude or find out the diagnosis of dementia with Lewy bodies. Usually these patients' main complaint is cognitive decline, confusion, fluctuation in level of consciousness, episodes of disorientation, visual and or auditory hallucinations. The auditory hallucinations are much less common as compared to visual hallucinations. The cognitive dysfunction is enough to interfere with the social activities as well as other activities of daily life and their performance at work if they're still working. The dementia does progress much more rapidly as compared to Alzheimer's disease or even as compared to idiopathic Parkinson disease, and they do have associated aphasia or dyspraxia and spatial disorientation, and in addition, they have extrapyramidal motor symptoms. If you compare this with the dementia of Alzheimer's type, the cognitive deficits in the dementia of Lewy body disease, they are more acute. In the fluctuation in attention, they are more severe. And also, the executive dysfunction is more prominent. The psychotic episodes are much more frequent, and not only they are more frequent, but they are also much earlier. The memory deficits, especially the recall, they are they are a bit less severe as compared to Alzheimer's patient, and they could be a little bit late. The early onset of cognitive deficits and psychotic features and the presence of the linguistic and visuospatial impairment distinguishes this from the dementia of Parkinson's disease, which also comes in the differential diagnosis of a dementia of Lewy body disease. The diagnosis of dementia of Lewy body disease is considered with much more certainty when the cognitive abnormalities, as I said before, develop either before or within 1 year of the onset of symptoms of Parkinsonism. If a patient has had Parkinsonism for about 12 months or more before they develop the cognitive changes, then the dementia of Parkinson's disease could be more likely. The diagnosis of dementia of Lewy body disease is considered when dementia, visual hallucinations, and the periods of reduced cognitive responsiveness, they precede the motor signs of Parkinsonism. And hallucinations and the periods of reduced cognitive responsiveness, they are more prominent. Also, REM behavioral disorders may be used to support the diagnosis of diffuse dementia of Lewy body disease, because the REM behavioral disorder is early and a bit more frequent in these patients. There have been some guidelines established, the consensus guidelines for the diagnosis of dementia of Lewy body disease, which can help to differentiate this from the Alzheimer's disease and atypical Parkinsonism. These guidelines are quite helpful in most cases. So they could divide these patients into possible dementia of Lewy body disease and probable dementia of Lewy body disease. So if there are two core clinical features, then the diagnosis would be probable Lewy body disease dementia. And if there is a one core feature, then it is a possible dementia of Lewy bodies. The studies have shown that the sensitivity of diagnosis by using these criteria is about 50%. The specificity is much higher, close to 90%. And if you use these criteria very vigilantly, the diagnostic accuracy does increase. The core features are fluctuation in cognitive function and visual hallucinations. The central feature of all these patients is a progressive cognitive decline, which interferes in the social and occupational functioning. Also, in addition to the core features and the central features, the physicians can use the supportive features. The supportive features are usually falls, syncope, sensitivity to neuroleptic medications, or delusions and hallucinations, REM behavioral disorder, and depression. When these patients are assessed in the regular, in the routine and regular clinical encounters, the cognitive impairment is the main focus of the family members and the patients themselves. So the clinician has to take a lead to look at the supportive features, because the supportive features the family members or patients could attribute to other causes or age, such as repeated falls or transient changes in level of consciousness, or depression, as well as syncope. These are common in elderly individuals otherwise. And although these could be the red flags of dementia of Lewy bodies, but the patients may just attribute these to either arthritis or living alone or getting old, and so on. The neuroleptic sensitivity and the REM behavioral disorder, they could be highly predictive of dementia of Lewy body type. Overall, the accurate diagnosis of these patients does require a very keen and meticulous assessment of these patients' history, physical examination, and a very detailed mental state examination requiring the paper-based testing as well as other cognitive tests. In sometimes a help of the experts who deal with these cases could be required. And before one concludes the diagnosis, they should exclude the delirium, which could be due to many causes such as medications or infections, dehydration, or so many other drugs.
Very good, Dr. Rana. That wraps up part one. Is there any closing remarks you want to say about Lewy body dementia and Parkinson's before we close?
Dementia with the Lewy bodies is a very interesting condition, but at the same time, it is very challenging to tease out the details and differentiate from Alzheimer's disease or idiopathic Parkinson disease or atypical Parkinsonism, and dementia Parkinson disease could be quite difficult. So I think on the first assessment, the clinician should do a very detailed history, physical, and other paper-based testing, and the patient may need to be seen a second time, and a parallel history from a family member or a caregiver is very important in reaching to a diagnosis.
Okay, very good. Okay, that wraps it up for part one of Lewy body dementia and Parkinson's. Stay tuned for part two on Parkinsonism TV, and I'd like to give a shout out. Oh, good evening. Thank you, Dr. Rana.
Thank you, Dr. Bennett.
And I'd just like to give a shout out to a couple of people watching. Simon Downs, Japanese medical student, my nigga, from Tokyo. He's going to medical school there, and John Hewitt in Philadelphia. Thank you, Dr. Rana. We'll see you for part two.
Sure. Thank you very much, Dr. Bennett.
Thank you.